insurance industry Trojan horses in single payer proposals. And as a preliminary thing, I want to discuss the significance of the concept of risk or insurance risk or financial risk, because I think it's fundamental to understanding why this is such a serious issue. Risk, basically risk is who covers the variability in healthcare costs from year to year. Some years you'll have a pandemic, some years you won't, some years you'll have several patients with extremely expensive conditions, such as a premature infant that's going to need lifelong care due to multiple birth defects, or someone with who needs a bone marrow transplant. You get several of those in one year and you'll have a higher cost. So the cost of care is sort of a jagged sawtooth graph from year to year that goes up and down. And the entity that has insurance risk is the one that has the money and is responsible for paying providers of care and covering those ups and downs. If a state were to, or a country were to retain insurance risk, they would have a somewhat variable healthcare budget, but they would end up paying the average of those ups and downs. If the state contracts with an insurance company and says, okay, we'll give you a fixed amount of money and you've got to cover the cost of care, that insurance company is going to charge you the top end of those ups and downs. So there's always a premium that you pay to contract risk out to some third-party middleman, some other entity besides the state or the government, which is collecting the money for healthcare. So every time you shift risk to some sub-entity, you're going to pay a premium for doing so because they're going to make sure they charge you enough where they're not going to lose money. But that's the problem of insurance risk. I had a friend who was an architect and project manager, and we were talking about this issue of risk in healthcare. And he said, risk, you want to avoid risk as much as you possibly can because you will always pay through the nose to give somebody else risk. So his idea is in construction, you want to nail every detail down so there's nothing left that's uncertain. And that way you can hold costs down because you're not having to pay a premium for your contractor to take on a lot of risk. So this is really essential to understand in healthcare because there's been a fad over the last, at least since the 80s, of, because healthcare costs have been rising faster than inflation in this country, they came up, policy people, the insurance industry came up with this idea of, up to now, the insurance companies have had the risk. Government contracts with insurance companies and they take on the risk, or businesses contract with insurance companies and they take on the risk. How about we push risk onto doctors and hospitals so they have the incentive to restrict care instead of us? And this idea was behind the HMO movement in the 80s, and it's behind the ACO movement now, and it's embedded in a lot of the features of the Affordable Care Act. It's pushing risk onto providers of care. So if you pay an organized group of doctors and hospitals a fixed amount of money per person, and then hold them accountable for covering all of the healthcare needs of that population. That's what shifting risk onto providers of care means. And this is called an HMO or an ACO, Accountable Care Organization. The difference is that an accountable care organization, members are assigned by where they go for care most often, rather than being signing up for an HMO like you do with a regular HMO. If you're going to be in Kaiser, you sign up for Kaiser and your care is restricted to Kaiser, whereas with an ACO, if you see one primary care doctor 4 times in a year and another primary care doctor once, you'll get auto assigned to the first one and he'll get your monthly payment for your care. But once you transfer risk onto providers of care, then they have an incentive to restrict care because the less care that's delivered for their population, the more of the money they get to keep. They also have a very strong incentive to cherry pick and lemon drop their patient population. Because the big problem with risk in healthcare is that way too much of it is predictable because of pre-existing conditions, demographics, social determinants of health. So if you already know who's going to be high risk and who's going to be low risk, and you want to make money off capitation, you start cherry picking your population. You only take on easy, patients who are rich enough to afford their copays for their drugs, and you don't take on sick people, poor people, people with complex problems who are likely to cost more. So lemon dropping means getting rid of high-risk patients, and cherry picking is holding on to low-risk patients. And since too much of the risk is predictable, when you have competing risk-bearing entities like insurance companies or ACOs or HMOs, the way you beat the competition is by getting a healthier risk pool than they have and dumping the sick people onto the competition. And that's what drives that's what determines success or financial success or failure with a competitive insurance situation. And we have been relying on the competitive insurance business model ever since World War II to fund healthcare in this country. And so we've had pervasive problems with denial of care and excessive administrative costs. And the Affordable Care Act and implementing accountable care organizations has just given this a new form that works exactly the same way. You get the money up front, you're responsible for covering the care, and you either make money by delivering less care, or you lose money by delivering too much care or referring people to expensive other doctors who deliver too much care. So the idea is to push the financial incentive onto providers of care. Now, no one has actually demonstrated that this saves money. It does result in some reduction in utilization of care. But when you shift insurance risk onto doctors and hospitals, they will say, obviously, but that's not fair, because if we take on sicker people, we're going to get punished. So why should we take on sick people? And isn't that the whole purpose of health insurance? So the supposed answer to this is risk adjustment, where those that are administrating the ACO try to get as much information about the patient as they can. They're all their diagnoses codes, and the more diagnoses codes, the better. And then they use that to calculate an expected cost of care for that person per month or per year. And if you take on a sicker patient, they're supposed to adjust the payment up to account for that. And if you take on a healthy patient, they're supposed to adjust it down. Now, the problem is predicting cost of care is too complicated to do accurately. So they use crude measures that capture maybe 10, 12% of the variability in cost and use that to risk adjust. But of course, that leaves 80, 90% of the cost of care still being caused by factors that are not being captured in the risk adjustment formula. And so everyone still has an incentive to cherry pick and lemon drop. And if you try to make risk adjustment more accurate, you need to gather more detailed data, and that adds administrative costs and administrative burdens. And we're already at a point where those are excessive. So, and if we have excessive administrative burdens at 12%, and you're trying to get to 16%, and you end up doubling those burdens, you're in a situation of diminishing returns, and you cannot make it work. You cannot get to a point where risk adjustment is fair or actually effectively adjusts risk, and you're still left with incentive to skimp on care and cherry pick and lemon drop. And this has been blatantly what's happened with the Medicare Advantage program, which is supposedly risk adjusted. But despite that, the Medicare Advantage plans have all gotten very good at capturing a healthier than average risk pool in order to make money and pushing sick people back onto regular Medicare. And they do this with marketing. They do it by restricting formularies for expensive conditions, by prior authorizations, basically hassling people with serious expensive illnesses to drop out of their plan and go back to regular Medicare. And there's pervasive evidence that this happens a lot. So when we're coming to propose single payer bills, and I'm going to start with Bernie Sanders' bill, S1129, which tries to control costs by using HMOs and ACOs. So you now have multiple risk-bearing organizations involved, and they are in competition with each other, and you have the same incentives to deny care and cherry pick and lemon drop, and you have the excessive administrative costs of the model. There's no cost savings in that. You're just perpetuating all the flaws of the current model. And it's been very difficult to persuade Bernie Sanders to drop this feature from his bill, because he's being influenced by, companies such as Kaiser that are risk-bearing entities, and they say, well, we have a huge market share in California and Washington and Oregon and Hawaii, and we're expanding into other states, and you can't just dump our patients, you have to include us, so allow us to use our HMO or ACO model as a cost-saving measure, which is what its rationale is supposed to be, never mind the fact that it has never actually achieved that goal. So the result is that of this kind of lobbying and of the fact that there's a policy fad that supports risk shifting, we're getting single payer bills that have ACO and HMO loopholes in them. And that sabotages the cost savings of the bill. The other thing about this is that there's extensive evidence that the most cost-effective way to pay hospitals is with global operating budgets. And this is the HR 676, the PNHP bill, and the current Jayapal bill, HR, what is the number?
1976.
What? 1976, yes. Those do have no ACOs or HMOs, and they do have global budgeting of hospitals. If you globally budget a hospital, you're paying the hospital what you think it will cost them to run their operation, but you're not paying them per member. And you're not locking them into, this is your budget. If you deliver less care than this, you'll make money. If you deliver more care than this, you'll lose money. If you budget a hospital, you say, this is what we think it costs to run your operations, but we're not expecting you to take risk. If something happens like a pandemic and your costs change, we can go back and renegotiate your budget. You are expected to generally try to live within a budget, but if circumstances change, it can be renegotiated. And you don't have a situation where the hospital makes or loses money depending on how much care they deliver. Their job is they're being paid to do a job, and they try to do it the best they can. And if something unexpected comes up, they can come back and ask for it to be adjusted. If you pay hospitals with a global operating budget, and not a capitation budget per member, but a global operating budget to give them what it costs to do what they need to do, then you're not shifting risk onto them. If you do budget a hospital like that, what you do is you eliminate billing and collections because they're already paid for everything they need to do upfront as a budget. And billing and collections are roughly 15% of a hospital's total budget. And so that takes 15% or almost 15% because there might be some billing and collections for out-of-state people, out-of-country people who come through, but it's going to be a far smaller operation than what hospitals spend now. So you're going to take 13, 14% of the hospital's budget right off the top by paying for hospital care with global budgets. There's a question of how is the global cost determined? It would be determined initially by taking the hospital's current cost for hiring the doctors who are hospital employed, hiring the nurses, hiring the physical therapists, hiring the housekeepers, hiring the security people, everyone who's needed to run a hospital. And this cost of supplies, the cost of real estate, all those things, you add it all up and say, okay, we'll give you this budget. It doesn't include most of your billing and collections, but includes all the things that we know you need to run your hospital. And then you adjust it as you go along. So that would be how you would determine it based on past experience and eliminating the things that are unnecessary with global budgeting. So that is the way to pay hospitals if you want a cost-effective system. But if you're going to pay for hospital care as part of your capitated payments to an HMO or an ACO, you've eliminated the option of paying the hospital global operating budget. So you can't do both. You have to make up your mind. Are you going to pay the hospital the budget, or are you going to pay an ACO or an HMO to cover hospital care and try to restrict it because they have a financial incentive to deliver less care? So we feel that any single payer bill at the state or federal level ought to specifically exclude risk-bearing, competing risk-bearing entities, ACOs and HMOs and integrated delivery systems, and specifically authorize global operating budgets for individual hospitals. Now, so the question is, what happens with Kaiser? So Kaiser has three parts. It has a hospital, it has a doctor group, and it has an insurance function. And the insurance function collects premiums, calculates insurance risk, does underwriting, all of that kind of thing, and makes sure that the operation makes money from charging enough in premiums to make sure they don't lose from the ups and downs of healthcare. So what Jayapal's bill does is it preserves the hospital and doctor parts of Kaiser by saying if a group of doctors is affiliated with a hospital, a single hospital, and they want to maintain the arrangement they have under Kaiser where they get paid through the hospital's budget and they pay their doctors with salaries instead of independent doctors who have no employer and must be paid with fee for service or some other arrangement. So they say, okay, the doctor group can affiliate with the hospital, will give you a global operating budget that's enough for both the hospital operations and to pay the doctors, and you can pay the doctors with salaries, and you can have your doctor hospital integrated system. But we're going to budget each individual hospital separately, and we're not going to give you money to establish a chain of hospitals, and we're not going to give you money for insurance functions because you don't need insurance functions if you're being paid an adequate operating budget by the single payer. And by eliminating the insurance functions, you save quite a bit of money for the system. And this means that for Kaiser, the doctors are kept whole, the hospital is kept whole, but Kaiser corporate gets booted out. And the opposition to this is all coming from Kaiser corporate. It's not coming from the doctors in the hospital. Unless Kaiser corporate is saying, you can't talk about it, we're going to speak for you. And then they make it appear as if they're speaking for the hospital, but really this arrangement would not hurt the hospital or the doctors. You also have the purchasers of insurance, which is the unions and the businesses and the individuals who buy into Kaiser, who are happy with the care that they're getting. And they need to be reassured that your doctors in your hospitals are not going to change. You can continue to see the same doctors. You can continue to be treated in the same hospital. The only difference is we're not going to pay the overhead of the corporate chain, and we're not going to pay for the insurance functions, which you don't need because the cost is being covered. And you don't have to worry about surprise bills with out-of-network because there's no longer members. If a Kaiser hospital doctor group is paid by a single payer, they're not being paid by premiums. They're being paid a global budget. So there's no such thing as members. And anyone can go to Kaiser and to another hospital or back and forth without it being a problem because they're not locked into a closed system the way current Kaiser is. So it would make Kaiser open. It would reduce its administrative costs, but it would preserve the physician and hospital parts of it. So this is a solution that's written into Jayapal's HR 1976. And it's what we think every state level single payer bill should also do is specify this solution to Kaiser instead of trying to appease Kaiser corporate and leaving in HMO and ACO loopholes. So that's the nutshell version, and I would like to open it up to questions, comments, discussion, whatever anyone would like. Let's look at the chat.
So yeah, does everybody know how to use the raise your hand image? You go,
Yep.
okay, down at reactions on the right bottom, and you click on that and you'll find one option is raise hand. So please do that, and then that helps us keep track of the queue. But I think Corinne and then Lynn.
Thank you. I have two questions. One is, one of the good things about Kaiser, I think, if I understand it correctly, is that they have specialized hospitals, and that's one of the ways they increase quality. So if you have a certain, if you have heart disease, you go to the hospital where there's more experience with cabbages, or if there's orthopedics, you go to a hospital that has more experience with orthopedics in the general area. So I'm wondering how that would, what we can tell people about that. And then the second question, and I'm not sure because I came 10 minutes late, is, can you give the argument about why fee for service is does not contribute to the high costs of healthcare? Because even doctors, I've heard it from doctors, think that that is a major determinant of the high cost of healthcare.
Okay, good questions. The first thing is that with global budgeting of hospitals, all those specialty hospitals will also be globally budgeted. And if a patient needed specialty care, because there would be no closed panel network, anyone would be free to go whatever hospital they needed to go to. And the doctors at your primary hospital say, this is something more specialized in what we do, you should go to that hospital, and there'd be no barrier to doing so. So that would really not be a problem. The other question about fee for service is that there have been studies looking at how the US compares with other countries, and our doctor visits per capita and hospital visits per capita are toward the low end of the range. And these studies were done over the last couple of decades from the time when everyone was paid with fee for service. So if we're having the low end of doctor visits per capita and hospital visits per capita under fee for service, it's not possible to argue that fee for service is the cause of our high costs. And there are also multiple studies that show that the difference between the US and other countries is not utilization, which is comparable to those other countries. In fact, it's less than many of those other countries. It's administrative cost. And when you organize doctors and hospitals into ACOs and HMOs and give them incentives to deny care and cherry pick and lemon drop and have to counteract those incentives with risk adjustment and pay for performance incentives, you're adding administrative costs. All those things add administrative costs. So the result is there's always pockets of excessive or inappropriate utilization in every system. Every country has those pockets, but we have no more than any other country. What we do have is way more administrative overhead, way more. And that drives high prices. And that's the difference. That and the high cost of pharmaceuticals are about 90% of the difference between what we spend on healthcare and what other countries spend on healthcare.
Thank you.
Thanks. Next was Betty Dumas.
Yeah. Hi. Thanks for having this today. Yeah, there's in California we have AB 1400. I'm not sure if you're that familiar with the state bill, right? So this bill doesn't have ACOs or HMOs.
Right. It does it right.
Yes, and
it's a
so
good
there's
single
this.
payer bill.
So there's this rumor going around, and that it would get rid of Kaiser.
It would get rid of Kaiser corporate, but not Kaiser doctors and hospitals.
And there's no distinction there.
Yeah.
They're not making that distinction.
Yeah.
And unfortunately, so that's the pushback that we have. And there are some pretty prominent people out there that within the movement that are actually telling people this and trying to scare the bejesus out of them because everybody loves their Kaiser. Okay, not me in particular, but there are a lot of people that like Kaiser. So I'm trying to figure out what is it that, other than all the things I pretty much know, what could it possibly be that hurts Kaiser so badly? Okay, so yeah, but so I'm thinking about something you said. You said it does not allow a budget for the chain.
Right.
So it doesn't allow the budget for the chain. So in that respect, that it's a global budget for each hospital. Is that somehow some sort of deterrent that, or, that could cause a huge problem, do you think?
Well, as I said, it doesn't affect the funding for the hospitals or the funding for the doctors. There's nothing about the proposal in the Jayapal bill or AB 1400 that would eliminate funding for hospitals and doctors. It would indeed eliminate funding for corporate management of a multi-hospital chain. It would eliminate the possibility of profit because your operating budget, if you have anything left over at the end of the year, it goes into the next year's operating budget. You don't get to keep it. And so when people say it would eliminate Kaiser, it would eliminate the Kaiser corporate structure and would eliminate the competitive insurance business model that they rely on, but it would not eliminate the care aspects of Kaiser, the hospitals and the doctors. It would preserve them completely. There would be no compromise to them at all. Plus, you get the benefit, you don't have to worry about out-of-network billing. And I really think this is something that those of us pushing state-level single-payer bills need to be out in front on this issue and emphasize it and keep hammering it, that these proposals do not affect payment or the financial viability of the hospital or the doctors. They only affect the organization of multiple hospitals and chains and the use of the insurance business model. Those are the things that they do eliminate, but they do not eliminate the doctors of the hospitals. You're still free to go to your same doctor in your same hospital as long as you want. And there's nothing about this that would restrict that.
Thank you.
Thank you. Next, Susan.
Wait a minute, you forgot me.
I'm like, oh, okay. Do you have your hand waving? Is that Lynn?
Yeah,
Okay. Go ahead, Lynn, and then Susan.
yeah, I was supposed to be after Corinne. Anyway, I worked at Kaiser for 8 years, and I was a nurse negotiator with CNA. And my understanding is they wanted the profit in order to expand. And that's why they liked the extra money. And they refused, of course, to tell us what their, money was. They kept saying, they didn't have enough money to give the nurses contracts and stuff. But what I don't understand is Kaiser should be pleased because they will start getting more patients. People who don't have Kaiser now may hear about a great doctor. I worked at Kaiser Redwood City neurosurgery. Some of the top neurosurgeons in America are there. So people could start going there. And so I'm not quite sure why they're against it. And also, who determines the money given in these single payer proposals? They create a board and those people decide how much money they're going to give to each hospital.
Yes, that's essentially correct. And another aspect of this is that if you give the money to a Kaiser chain, they then determine where they're going to build a new hospital or a new clinic. And the way it is now, they try to target wealthier areas where they're going to get a more favorable patient population, and they try to avoid rural and poverty areas where they get a more difficult patient population because they're capitated. If they were paid a budget to do what they need to do to serve a population, and they're going to be in a high-risk area, they would get a bigger budget. And it's up to the board, the regional board, to balance the needs of different communities and try to make sure resources are distributed as equitably as possible, instead of having those determinations made based on business interests. They're made on a community need basis by a single payer board.
I have one more quick question.
Yes.
Okay, so that brought an idea. Okay, the hospital's global budgeting is given money, and that entity decides how much to pay the doctors, correct?
Well, I think another feature of a well-designed single-payer program should be standardized payment of doctors, at least within a region. And so the fee-for-service fees for independent doctors, if you add up a typical 50-hour week, should add up to about the same as the salaries for a Kaiser doctor. And there should be some means of making sure those things are equitable, so that you're not going to favor one setting over the other.
Thank you.
Next, Susan.
Okay, thank you. Stephen, I thought that was wonderful. That was a very clear and defined explanation of what is going on that was very easy to understand. I don't have so much of a question as I just want to make a comment, because when we talk about, if we talk about globally budgeting a hospital based on their history of how much they spent on salaries and how much they spent on supplies, etc., that we have to be careful about that so that it doesn't cause the inequities in hospitals persist. Because right now, a hospital that has a payer mix that is mostly Medicaid or Medicare is going to spend less on supplies, is going to spend less on salaries because they have less funds. That's what happened with the CARES Act and how they distributed money to hospitals, is that the hospitals that made the most money got the most help. And of course, those were hospitals that were already wealthy and with billions of dollars in escrow, whereas hospitals that had a poor payer mix received half as much per bed as wealthier hospitals. So I think if we are saying that a single payer system will address inequities, we have to make sure that how we fund and globally budget will take into account the inequities in funding that already exist so that they aren't perpetuated. And that's going to be difficult because, you know, when public education was supposed to be desegregated, it wasn't. And we still have such marked differences in the funding in public education now based on neighborhoods. So I just want to, you know, I think that if we are going to be stewards of single payer, this is something we really have to be on top of.
I think that that is an important consideration. It seems to me that a single payer board who sees their role as assuring equitable distribution of resources would have less reason to perpetuate that than if we just say, well, we're going to give you what you got before without thinking about it. And I also think that the idea of trying to minimize risk by getting as specific as possible in how you calculate things. So you don't say, well, hospital, what did you spend on supplies before? You say, what does it cost to buy so many chucks and so many surgical instruments and things like that? And you try to calculate it as the cost at a somewhat more granular level than just historical precedent. And you would, if you're trying to meet community needs, you would have every reason to be sure that hospitals that serve poorer and more complex patient populations get supplies that are commensurate with the population they serve and the neighborhood that they're in. So I would hope that those problems could be addressed fairly straightforwardly, but I think it's something we would need to be aware of in planning budgets.
Thanks, Marcia.
Yes, thank you. I echo Susan's comment, thanking Stephen for his excellent presentation. It's a really good way to start out. My question might have been already answered, but I know you held up the example of Kaiser Permanente, but that can't be the only bad guy in the equation or in the room. There must be others, and you did mention multiple hospital chains. Are there other? I mean, I want to figure out how strong is the lobby against what single payer people are trying to do.
Well, there are plenty of other multiple hospital chains, many of them for profit, that would also lose under the system, but they're not all organized as capitated HMOs the way Kaiser is. There are some that are. Kaiser is certainly not the only one. But what I'm trying to say is that our enemy in this it's not the hospitals, it's the competitive insurance business model. And it's organizing hospitals to be able to take on capitated payment insurance risks. That's the problem, not having all these hospitals. And it's siphoning money out of hospital care to support corporate empire building. Those things all need to be eliminated. But we want to support hospitals. We want to preserve all the hospitals we can and make sure that they're adequately funded. And we're going to get the money to do that by eliminating the corporate chains and the insurance functions of the Kaiser-like entities and things like that.
A tall order.
Yeah, it is a tall order, and there's a lot of resistance. We need to be at every turn driving a wedge between those that deliver care, the hospitals and the doctors, and those that have business objectives. And we want to separate them, drive a wedge between them, and be ready to cut out the business interests in order to come up with a cost-effective single-payer system. And if we don't push the business interests out first, but we allow them to stay in because it's too politically difficult, we will end up with something that doesn't save money and doesn't work and doesn't solve the problem. There's just no way around that.
Good. Nancy.
Hi. I would also like to echo appreciation for this session and appreciate you're trying to educate us all. I'm finding it difficult to be educated. I still have some confusion. In fact, I just sent you an email. What I don't understand is that if you have a global budget for a hospital, and that is for their operating expenses, which includes both the salaries of the workers as well as all the materials that they need, that would be calculated on the number and severity of illness of the patients they treat. So I'm having difficulty understanding what is the difference then between a global budget, which would have to be based in part upon the patient population and again, estimates of risk versus a capitated system.
That's a good question. And there is a fundamental difference. And the fundamental difference is that a hospital paid with capitation is being paid per member. It has to have members. So with an HMO, you have to sign up for the HMO, or your employer has to sign you up for the HMO, but you are assigned as a member of that HMO. With an accountable care organization, it's somewhat looser in that you're attributed to a particular doctor based on where you go for care. And if you change doctors, that causes a lot of confusion. But in either case, you become a member, whether you do it deliberately yourself or with somebody auto assigns you to be a member. And then the hospital or the hospital and doctors together are paid on a per member basis. With a budget, you're not paid per member. You're paid for what it costs to do what you do. You're paid to cover your operation costs and the salaries of your doctors. And that may be adjusted according to the population that you serve. If your hospital is in a poverty area where there's a lot of chronic disease, more than there is in a wealthy suburb, that hospital should get more resources to cover that. But you're not paid per member. You're paid what we think it would cost you to do what you need to do to deliver the services that you provide. And that can get adjusted. The budget gets renegotiated every year. So if it's misjudged one year and the hospital is able to show the evidence why they were not treated fairly, that can be adjusted in the following year's budget. But the hospital does not make or lose money by how much care they deliver. They are given a budget to deliver the care that they are set up to deliver, and it can be adjusted based on changes in circumstances, but they are not either making a profit or sustaining a loss by how much care they deliver, the way they are with capitation. The idea of capitation is we're pushing the risk onto the doctors and hospitals by saying your budget is fixed. You either deliver less care and make money, or you deliver too much care and you lose money. With a budget, you're said, this is what we think it costs you to do what you do. And if there's a reason why we miscalculated it, come back to us and we can renegotiate it. And you're not being told you're at financial risk for delivering care.
That's very helpful to me. I just to add, let me add to a previous question, which was that the JPAW bill has the operating budget, the capital budget, and also the special projects budget, which is dedicated to increasing resources to the underserved and rural areas. So it's built into the bill to take care of, underserved areas.
So Susan, your hand is still up. Do you have another question?
Well, I wanted to say something about that because I think that global budgeting should apply to hospitals. It should also apply to community health centers. It should also apply to specialized programs for, say, patients who are in and out of the emergency room a lot and need extra resources, or who are having complex health problems managed in home with extra home and community-based services. All those things should be community-based programs paid with a global operating budget, what it costs to do what they do, and made available to the community based on patient need, rather than having the money funnel through a risk-bearing entity that has an incentive to deny care and avoid sick people.
So I see Consuelo and then Susan.
Hi, thank you very much. I am new to this, and this is very fascinating to me, so excuse my ignorance in my questions. Um, This is, I learned so much from you. Thank you so much. I was wondering if I could work on your expertise and if you could give me or share with us a couple of countries that we might follow as models to see how they reduce inequity within a universal healthcare format of the global budget. And what are some studies that you like that we could read?
Well, the countries that do global budgeting the right way, the best examples are probably Canada and Scotland. Many other countries with single payer or universal or even multi-payer universal systems do not pay hospitals global operating budgets. They let them charge fee for service, and the hospitals do their best to pad the bill and charge you $10 for a Band-Aid and things like that. But both Scotland and Canada do pay hospitals global operating budgets. I think there may be other countries, but those are the main examples that I'm aware of. And there was a Himmelstein-Wohlhandel study a few years ago looking at the cost of hospital care depending on how they paid hospitals, and that one cited Scotland and Canada. I don't have the name of the study offhand, but I could dig it up and put it in the chat.
Okay, Susan.
Yeah, hi. I just had another question. And I've thought about this, Steve, and never really could figure out how we would approach this. But what do we do about areas? Because one of the things that we promote in single payer is to put services and resources where they're needed, not where they can make money. And where I worked at Cook County Hospital in Chicago. And within that, like 1 mile radius, there was the University of Illinois Hospital, there was a Jesse Brown VA, there was Rush University and their hospital, along with Stroger. All of these hospitals had extensive cancer treatment centers, interventional radiology, all of this high cost medical care that would be redundant in a single payer system to have that all grouped together, while a mile away there was a medical desert. So how would we adjust the budgets of these hospitals so that they all don't duplicate the same care just because they had been doing it before?
Well, I would imagine there would need to be a transition process from the way things are to the way things should be. And that means there needs to be some overall planning going on in a single payer system of saying, we really should have a hospital over in this desert 3 miles away instead of having 3 hospitals over here at the edge of a wealthier neighborhood or whatever it is. And then you would start negotiating with a hospital to either move or to expand a hospital that's in the desert area and shrink a hospital that's in the wealthier neighborhood. But you probably need to do it in stages, and you would try to negotiate with the hospitals to see if they would be willing to participate in this, because they're not in a situation, under single payer, they're not in a situation where they're going to make more money in one neighborhood than another. They're going to get their budget covered in either case, and they may as well go with where the need is. So, but there would need to be some strategic planning involved for this to work.
Yeah.
There have to be.
Thank you.
Are there any other questions?
Michael, this is Hal. Can I ask a question?
Yeah, please go ahead.
Yeah, hi, this is Hal Stockbridge in Seattle. Stephen, this is great. I have another question about global budgeting. I'm fairly familiar with the global budgeting process in British Columbia, just a little bit north of our state. And I'm wondering if what you've been describing, I think it makes perfect sense. Everything you've said makes perfect sense. And in British Columbia, they've been doing what you've described for decades and decades. And I think it's worked very well and quite smoothly. And I'm wondering if the process you're describing is exactly what they do in British Columbia and other parts of Canada, or are there some differences that you understand?
Well, there are many ways in which countries that had been doing it pretty much right have been corrupted by arguments from mostly from the US for doing more risk shifting. And that may be happening to some degree in parts of Canada, maybe some more than others. I know that in the United Kingdom, England has moved much more towards the risk shifting ACO model, whereas Scotland has held on to global budgeting. And so these things are under attack all the time by those who want to siphon money out for corporate interests. And I'm not an expert in what's going on in different parts of Canada to know what the latest is on this, but I wouldn't be surprised if there have been some efforts to compromise the principle of a well thought out global budget.
Lynn, again.
Yeah, it's maybe a stupid question, but maybe Stephen answered it. But these hospital groups like Kaiser, will single payer make it so that they don't get the profits they're getting now? And how do they expand if they want to build another hospital somewhere else? Where do they get the money?
That's a good question, because that is very clearly in HR 676 and HR 1976, that capital budgets, which is the money for expansion or new facilities or things like that, are separated from operating budgets. And capital budgets are allocated by the single payer based on community need. So if a community, like Susan Rogers' question, if you have a community with 3 hospitals and a nearby community with none, and you want to move a hospital into that other community, you start planning for that and adjusting the budgets so that it becomes possible to build or expand a hospital in the underserved area and shrink a hospital in the overserved area. But yeah, the capital budgets are separate. They're allocated according to community need, basically a grant system where the hospital says, we want to do this, here's why. And the single payer board will say, well, we have so much money for capital expenditures and we agree you need this, or we don't think you do, or whatever. But they would be looking at it from a community need point of view rather than a profit point of view.
Nancy and then Lynn again.
Yeah, thank you. It's dawning on me that, the HMOs have figured out a way to do cost savings for themselves so that they can come away with a profit. But how do you see cost savings occurring in the single payer bill? I understand that, salaries and payments would be negotiated, and I can understand that. But with the hospital and the global budget, it seems like it's open-ended. Like if they keep spending more, then you readjust the amount up. So it's like a credit card, giving a teenager a credit card, go and spend whatever you need and I'll cover it. How do you avoid that?
Well, the 2 things. One is the savings are on administrative upfront. So like the cost of billing and collections, you can knock off the top.
Right.
The cost of the corporate chain, you can knock off the top. Profit, you can now knock off the top. So those savings are off the top. But that's what I was saying before. If you, as the payer, the single payer, you want to minimize all kinds of risk. And one of those is you don't want to let the hospital say, give us the money, we'll figure out how much it costs, because they're going to lie to you about how much it costs because they want to be padding their budget. So the single payer needs to find out as much as they can of the details of how much stuff actually costs as a starting point for negotiations. So instead of the hospital saying, you give us the money and we'll charge $10 for a Band-Aid, the single payer says, how much do Band-Aids cost? And if you get into some of the nitty gritty of the actual costs, you should be able to come up with a much more accurate budget that doesn't just say, you tell us what you think it costs.
Okay.
Well, Susan? Or no, I'm sorry, it was Lynn?
Actually, I didn't have another comment, but Henry Broska has posted some really interesting comments. One is about a new system in Canada. Canada has mostly moved to activity-based funding, appealing because it creates an incentive structure that the global budget cannot. And he had another comment earlier, so I don't know if he wants to speak.
I'm not sure what activity-based funding is. I was wondering if it's something like our diagnostic-related group funding for hospitals, which is a form of risk shifting, of saying that, okay, for a given diagnosis, we'll pay X amount, and if you can deliver care under that, you can keep the difference. So that's a risk shifting scheme. I'm not in favor of that, but I do think we need to frequently review global budgeting. If we do global budgeting, we need to frequently review it, find as much as we can about actual costs, and keep renegotiating and try to make sure it stays cost effective, and have a balance between making sure the hospital stays viable and the needs of the community are met, but at the same time, they're not able to pad the bill too much.
One other comment. I think the reason the AMA is anti-single payer because it has its biggest percentage are specialists who make a lot more money than primary care physicians. So it sounds like based on the global budget of where they're working, so if there's just an outstanding doctors group, not necessarily affiliated with any hospital, they would get a global budget.
If they are affiliated with a hospital, they could get a global budget through the hospital. Otherwise, they would be paid, if they're independent, they'd be paid fee for service. And you try to calculate the fees so that a reasonably busy doctor would make roughly the same income as an employed doctor in a group that's affiliated with a hospital.
Because anesthesiologists, orthopedic surgeons make a lot of money. What do you think will happen to them under global budgets?
Well, this is a whole other topic that I also have thought a lot about, of what's the best way to pay doctors, especially those who are not salaried because they're an independent practice. And I do think that there are much more incentive neutral ways to do that. There are fairer ways to do that. I would not just perpetuate the Medicare resource-based relative value scale system for determining fees that we have now. I would want to rethink that and try to make it more incentive neutral. There's another proposal I read recently that says for primary care clearly needs to be better paid. Primary care doctors are being starved out of business, and that does not make for a cost-effective healthcare system. But you could have a patient with a chronic condition who wishes to have that primary care doctor manage a chronic condition. Their payment would be a monthly payment. Whereas a patient who comes in because of an acute illness or a minor injury, that would be fee for service. So you would have preventive care and chronic disease management as a monthly payment, and the rest as fee for service, and have a blend of the two. And that means that in a pandemic when no one can come into the office, at least you're still getting your monthly payment, and you can take care of those people's chronic conditions by telehealth or over the phone, and you're not going to be punished for it. So some blend of the two would make sense, but I would not make those monthly payments tied to financial incentives and disincentives. It would be like globally budgeting hospitals. You pay the doctor what you think it costs to manage that condition, and that's what they get, but you're not saying this, you're at risk, and if you take people that are not as sick as you make them appear to be, you're going to make money, and if you take on sicker people, you're going to lose money. It could be negotiated based on the actual cost as you go along.
I have one more question with Dr.
Yeah.
I haven't read AB 1400. I worked on healthcare for all SB 840 twice. And there was a section for care, delivery of care. Is there a section in 1400 about doctors and how they fit into the system and how they're paid?
I believe so. I think it's like HR 1976. The doctors would be paid fee for service or salary depending on their practice setting.
That's true. The AB 1400 was basically modeled after the Jayapal bills.
Henry Broska?
Yeah, hi, Lynn. I just mentioned it, and I think we're at a pretty early stage here to talk about the difference between, global budgets, activity-based budgeting that a lot of European countries have gone to, and activity-based funding, which is being tried in Canada right now, and they've had experiments in various provinces, and some are moving over to that. We're not quite there yet in this conversation, but and rather than take up any time talking about this, I posted a link in the chat on activity-based funding of hospitals and impact on mortality, et cetera. And you can probably get that article, everybody here, and then just kind of read it and familiarize yourself with it. But as everybody knows here, I'm come from the Canadian system, and now living in the United States. But I could probably get together and do a presentation on the differences between these budgets, and work with Stephen on this, but also some of my friends who are actually working on this at an academic level in Canada. If that might be something that we could do on this with this group.
I think if we ever get close to actually implementing a single payer system, this would deserve a lot of thought.
Well, there are methods. I mean, the methods are well known. It's a well trodden path, and we should all familiarize ourselves with how other countries do it. And you're quite right. I also posted the study you refer to by Himmel Handler on the chat, and yeah, and it's there about Scotland and Canada.
Okay, yeah, I see it in the chat. Thanks.
All right.
So Nancy, you have another question? Your hand's still up?
Yeah, actually, I wanted to direct it to the Canadian physician, which is that I don't understand in Canada how I understand it's fee for service, but is there any of this upcoding that goes on? How does the actual bill work? Is it per time they spent with the patient, or what is it?
You want to know?
Yeah.
Okay. Well, the hospital has a different budget completely in Canada than the doctors that work in the hospitals. There are in some cases, hospitalists who work for the hospital, but that's only probably maybe 5% of Canadian doctors are actually hospitalists paid by the hospital. Most of them are working on a fee for service, and it's there is no gaming of the system because it's all a provincial code. Everything that they do. So if you're going to do a knee, you're in orthopedics, you're going to be paid $700 for doing, say, $760 for doing a knee. That's what you're going to be paid. So if you do 6 of them a day, you can figure out what you're going to make as a physician. But there's no gaming the system.
How about ambulatory visits in the outpatient setting? How is that done? Is it a standard fee for a?
Yes, yeah, it's a standard fee to be seen depending on age of the patient and so on. But Lynn, I think Lynn had mentioned, or somebody had mentioned, or that primary care or family medicine was a lot more prevalent in Canada, and that's true. They're graduating 45% of all the doctors in Canada are family medicine medical doctors, and they refer on to specialists. And in fact, those doctors, the family doctors, there's about 25 or 26 courses they can take now to extend their skills. And they will actually be able to do some surgeries. They do emergency medicine. They can do some orthopedic medicine. They do sports medicine. So it's a very interesting life for a Canadian doctor who does a lot more. And they get the specialist rates when they do the specialist procedures. So it's when we're looking at what Canada is compared to us, it kind of looks the same on the surface, but it's really not an apples to apples comparison.
It'd be great if you did a presentation on it.
I'd love to, sure.
Well, I have a question that my CEO of our hospital chain would ask. Okay, you're asking us to build the hospital in this town over on the coast. And what protections are there in HR 1976 that the next administration is going to cut the funding and will be kind of isolated out on this island?
Well, I would say to that if you establish a single payer system, as long as that system is in place, it has a means to address that problem. But you can never guarantee that someone's not going to come along and wreck it in the future. Look what's happening to the British National Health Service.
Yeah.
There's no guarantee. All you can do is say, if we do it right and it works well, it's going to be harder to change than if you do it wrong and it doesn't work well.
Yeah. Yeah, Tommy Douglas back in what, 1970 said, yes, we've won it, but we're going to have to fight to keep it. And then speaking of British Columbia, I think it was just last year that the Supreme Court there finally turned back the effort of that orthopedist who was trying to set up basically to dismantle the guaranteed public system.
Brian Day, yes, he was in the court for 10 years, and there's always going to be attacks on the public nature of healthcare. Somebody who's always going to want to make profit off of it. So that's really what Canadians guard against first and foremost.
Any other questions? People who haven't asked questions yet. Hank, out in Maine, you have a question.
Yes, thank you. So I talked to rural CEOs of hospitals, and they say, oh, a global budget, that means I will survive. And then they just need to figure out what their coverage is and how many people they'll treat and do the the demographic studies. But if you talk to a big hospital CEO as a $500 million endowment, they say, what? I can't build a big new fancy wing? And the other rural docs, the rural CEOs say, so am I going to get paid quarterly? And how many days cash on hand am I going to be allowed to have? Because that's how they, view their fiscal successes. How many days cash do they have on hand? Any thoughts on how you would, how I would discuss that with them?
I think quarterly would be reasonable, and I'm not positive of this, but I think that's how they call for doing it in HR 1976, is quarterly payments. But I think that would be reasonable, and that's enough time to where you can plan, but not so long that if something really changes like a pandemic, you can't make adjustments.
So I can tell them they can have 90 days cash on hand?
Yeah. Yep. You'd be given a 90-day budget, and then it would be renewed after 90 days. And if it needed to be adjusted for some reason, for some good reason, it could be. And of course, the capital expenditures for the big hospital in the city would have to come from the separate budget, and they'd be based on community need. If it's needed, they'll fund it. If it's not, they won't.
Thank you.
So, Patty Harvey, Northern California, you have a question, or Kay Laster.
I had a question in the chat about waivers. I don't know if that's germane to this conversation, but it seems to me it's something that could be easily answered. What really has to come first? According to NNU, you have to have the state has to have a plan actually in place before you can apply for waivers. And that was news to me. I had no idea that that was the case, particularly because one of Governor Newsom in California's first act as governor was to suppose that what I've heard was to apply for waivers for California to the Trump administration, which was a pretty safe bet, obviously. And but we had no bill at all. So I don't know, how does that work out?
With waivers, at the state level, the problem is you've got to capture the huge chunk of healthcare that's federally funded. All of Medicare and over half of Medicaid is federally funded, plus federal employees, the VA, other things too. So how do you capture you don't want to lose all that money by setting up a single payer system. So you got to get waivers to get it. Obviously, if we got HR 1976 nationally, that wouldn't matter because it would not depend on, the federal, it would all be federal money then. Now, there's another thing I was thinking of with that. I think what we're talking about here is if you want to pay hospitals in the most cost-effective way, these are things that should be considerations. We should be thinking in terms of budgeting. We should not be thinking in terms of risk shifting. But once you get a specific proposal, the waiver problem is how do you capture the federal dollars? And the more cost effectively you've designed your system, the less federal dollars you need to depend on. So it's helpful to have a cost effective way of paying hospitals, but it's somewhat of a separate issue. It's, the issue with waivers, how do you capture the federal dollars?
Well, my question was, to capture them, must you first have a plan in place?
I think so, yes. So you'd
Well,
have
it makes
to have,
perfect sense to me. It makes
you'd have
perfect
to have
sense
a-
to me.
you have to have a specific proposal and be able to say, this is how much it's going to cost.
Right, exactly. But there seems to be some disagreement among people in this movement about that. And I'm not sure how that can be, but apparently it is. I also wanted to comment, Henry Broska will be appearing a week from tomorrow for our group in Northern California, HCA and PNHP. We are hosting him to give a talk about this very subject, Canada's healthcare system, and what it has to teach us. And anyone that's interested could email me and I will send a link to them. And I will put the email in the chat.
Other comments? Henry Elder, Michael Goodman, Betty Valencia.
I really just have a comment. Thank you. Thank you so much for this. Every time I listen, I learn so much, Stephen. So thank you so much. And I'm hoping that we can have more of these and invite, more individuals, particularly here in Orange County, who should be at these workshops. So I guess my question would be, could we have more of these, especially now that we really need to get people on board? Well, how open is OPS to organizing that?
Well, some of us are online right now. Barbara Pearson, myself, and Stephen is also involved, and we take your challenge. We're going to have at least one office hours like this per month.
Great.
And one similar session, which we have on third Friday mornings for the general meeting. And the one coming up will feature Alex Lawson, who is in Washington, D.C. with Social Security Works, and he'll be talking about sort of high-level petition building and influencing legislators. So we'll have probably 2 events a month, and so we certainly want to get ideas from everyone. What are people interested in? One thing tomorrow you're all invited to, and I'll put the flyer in, is equivalent of a one pair states office hours. And the speaker will be Warren George, and his topic will be how to finance state-based universal health care. He'll be speaking for about 25 minutes, and then one of our local state legislators, who's also on the task force that we have for universal health care, will be on the panel, as well as the CEO of our 5-hospital chain, who I was just thinking a while ago, being reluctant to invest in a desert if the next administration is going to change. So anyway, I'll put those notices in the as a file in the chat. See, next is Lynn.
I know this may, oh, wait a sec here. I know this may be an odd question, but Stanford is very well endowed, gets a lot of money. I'm sure it's international because international patients come here. With single payer, are hospitals going to be allowed to take money like that?
That's something that has occurred to me and I've wondered about it and I don't know the answer. I haven't really thought it through, but I think it's a good question. There may be some way that that can be worked in, but you don't want hospitals to be depending on charitable contributions for their operations. So if there's some way that that money could be used for expanding access to an underserved group or something, but presumably you've got the single payer that's looking out to making sure the hospital stays viable and you don't need to rely on that kind of thing. And I'm not sure what the answer is, but it's a good question.
Next is Nancy again.
Yeah, actually, I know this. So there were two questions. One comment and one question. The question is, when you say you have to have the policy in place before requesting a waiver, as you know, the AB 1400 in California is just a policy bill. The funding mechanism is not included in it. So would the state have to not only have a policy in place, but also a funding mechanism specified? Because clearly not all of the funding is going to be covered by folding in federal dollars.
Well, one thing about that is I think that if you start by trying to say, how are you going to fund it? That really depends on how it's structured, which determines how much it costs. And if you structure it in a way that does not have much cost saving in it, the question of how you're going to get it funded is a much bigger question than if you've structured it so it's going to cost 20 or 30% less than what we're spending now. So to me, you have to nail down the policy details first, then you have to cost that out, and then you can talk about how to pay for it. And if you can't do it in any other order than that.
Okay, thank you. And I just, on the previous question, I could say that in the Jayapal bill, they raised the issue of if you have a philanthropist who wants to establish a new cancer hospital or something for their local hospital, they can do that. But that will require operating expenses, and to get operating expenses for that new capital purchase, you have to get special permission. I don't know what would actually happen, but they do recognize the fact that if you build some fancy new center, it's not just the building, but you're going to need to pay people to work in it. And that's an operating budget, which doesn't come from the philanthropist.
Yeah. Well, I'm glad somebody's tried to answer the question.
Well, next is Michael.
Yeah, hello. Yeah, I had a question. Does anyone have any idea what the current statistics are on whether more Canadian doctors are moving down to the US than US doctors moving up to Canada? I know for a long time there was quite a surplus of Canadian doctors coming down here, but I've been told in recent years that the pattern has shifted. Does anyone know what the stats are on that?
I don't know the stats, but there's an in-migration of American doctors to Canada now, that's for sure. And I personally know a couple. If you wanted to talk to them, I could get you their contact information.
Yeah, okay, thanks.
Okay, Michael, can you drop your email in the chat and I'll, hey,
sure.
Hey, there he is. Hi, Bill.
Good. Okay. We had Kay Lasker.
This question is slightly off, and I'm just curious if there are any studies that showed that by doing this global budget business, would improve the quality of medicine. And the work I've done in the past, I came across a whole slew of patients who had minor trivial procedures necessary, but the doctors essentially abandoned them and told them, and when I looked at it, it was specialists, orthopedics and dermatologists are the patients that I came across. And they needed minor, trivial little procedures that would sort of straighten out a little bit of a problem they had, but they couldn't get it. The other thing I found that some of these patients found their way over to the cosmetic industry to help them with, which was really a slightly invasive procedure and should be done under appropriate conditions. And of course, in the cosmetic industry, procedures weren't necessarily appropriate. So was there any statistics to show that you can improve the quality of?
Well, I do think that a well-designed single-payer system should fund quality improvement as its own funding stream. For 15 years, I was on the board of directors of the Quality Improvement Organization for Medicare for Hawaii, Alaska, Montana, and Wyoming. And we never used financial incentives. It was all based on doctors' desire to do the right thing. And we developed studies where you would track an issue that was thought to be problematic or where there was a lot of variability in how that problem was handled. And we would take that information back to the doctors who are doing it and have them help us design a standardized protocol. And that would bring them more in line with the protocol, and there'd be less variability, but it wouldn't punish them or reward them financially based on what they did, and they'd be free to deviate from the protocol if there was a good reason to do so. But that kind of thing, this model was developed a lot in Utah with Intermountain Healthcare. It's a continuous quality improvement model for healthcare. And I am very much in favor of that, but I'm not in favor of tying it to financial incentives. I think it should be based on doctors' desire to do the right thing for their patient, and maybe some shaming of doctors who are deviant in the way they practice. But there should be a significant funding stream for quality improvement, for monitoring quality, but it should not be tied to financial incentives and disincentives.
Good. Barbara. Barbara Harrison, you're muted. Barbara's in Eugene, Oregon.
I just want to say that I did a PowerPoint presentation that is on the PNHP members page about the crisis of healthcare in rural communities. And I did include global budgeting and a comparison to the Maryland plan, what Maryland uses. So it's just information on that. And Tom Sinsick has a copy of it.
Maryland has attempted to do what's called all payer, where
right.
all the different insurance companies have to pay hospitals the same thing for the same services, but they do it in a convoluted way that's administratively rather burdensome and expensive. And I think it could be done more simply, but I think the idea of if you can't get away from multiple payers, and there are many other countries with universal systems that do this, that have multiple payers, but they make them all pool the funds for hospital care, and then you can pay the hospital with a global budget, even if there is more than one source for it on a non-risk basis.
They have been told that if they apply for a single payer for a waiver, that they would lose that. And I had spoken with someone whose name escapes me in Maryland, who's very familiar with what is going on there. But you have to wonder how much the hospital association and what political strings, who's pulling the strings with that.
Yeah.
So it was quite interesting to do the research and to take a very hard look, because I'm interested in rural areas, at really how much they suffer by not having, they don't have enough GPs, they don't have services, and their health is so poor. It's really, but it's been very difficult to get the health movement. And I've been in New York to want to go and make connections with those areas. They're not interested in doing it. So the exclusivity in many ways of the healthcare movement troubles me a lot, makes me very depressed. So anyway, so that's all.
So I just wanted to remind people about tomorrow's town hall, and the flyer is in the chat. You have to click on it to open it up. And then the link is in a separate chat that is active link. So hope you can click that over and join us if you can tomorrow evening at 7 Pacific time. Anyone else that hasn't spoken up?
Mike, I'm going to go. We're having a steering committee meeting in of Lane County.
Okay, good.
Join
Hey,
that.
Carter,
I'm sorry, what?
just thank you for joining.
Yeah, thank you very much for this. And thank you from Hawaii. Maybe I'll get there someday.
Bill Bronson.
Steve, do you think that there's any possibility of gently opening up a conversation between Oregon, Washington, you, and California in terms of putting something really strategic together on a regional level? Do you think there's any benefit in that kind of effort that would change some of the conversation?
Well, the biggest benefit would be the bigger the program is, the more clout it has in persuading the rest of the country to follow suit, especially if we make it work. The difficulty is getting all the states to really hammer out something together, and the differences in state laws and the differences in state political cultures there's a lot of obstacles, but I think it's a great concept.
You know, we have key organizers. I mean, there are people, you know, like Mike and yourself and Dave McClanahan in Washington State. God knows, I mean, there's half a dozen people or more on this call.
If we get 2 or 3 states that are really moving in a similar direction, I think we should make the effort to pull them together. I think that's a very good idea.
Mike, what do you think?
Yeah, I agree. And to me, that was just a dream a couple of years ago. But through meetings like this, we're all getting to know each other across the country, but specifically on the West Coast, and talking with each other and learning from what Washington has just done and what we're trying to do with a task force. So I think we're building that direction for sure.
The bill that's being introduced by Ro Khanna on June 1st, that seems like it will be quite beneficial to states to be able to get the waivers. And then, of course, if you make a regional compact, so that will, I think, lessen the problem. New York State, I think, was poised to pass the New York Health Act, but Andrea Stewart Cousins, and I don't know if haven't found any information, pulled the bill from the committee. It's 3. Cuomo is a real SOB. He is not what, he was very beloved during the pandemic. He is not a good guy to be playing with. But they had enough people in the state Senate, because the Assembly always passes it, to pass the bill if they didn't turn tail and run, because they'll run on it, but the minute it leaves committee. And she pulled the bill last week out of the committee so that it could not be voted on tomorrow. And people have been calling her and asking her to put it back in. So it's just really unbelievable that here they were poised. So anyway, so that was just a comment about some of the difficulties.
New York has a superb war machine to deal with. If anybody can deal with it, New York can.
Well, but if you pull the bill before and not let it vote in committee, I don't understand. She's been an ardent supporter of the bill, a big supporter of the nurses, and this was all of a sudden this happened. So I don't know what's going to be. So I don't know if she'll put it back. Session ends on June 10th. So, I just found this hard to believe. What is her game? Who is she beholden to? I have to begin to wonder. Politicians, a hard group to trust.
So we're within 2 minutes of the hour and a half. And Steve, do you have any ask of the group? What would you like us to do?
This isn't an ask, but there were some questions about physician payment, and on the OPS website under policy papers, there's one on physician payment, one on hospital payment, and there's a Trojan horse one. So all of you have, you can look up any of these papers and read them from the website. And I encourage you to use them in talking to legislators and things like that.
Yes, and many of you received, notice of this meeting from a newsletter that also led out with instructions, guidelines for contacting key legislators to sign on to the new state-based universal health care, the one that's going to take the place of HR 5010. So please do that if you haven't already, and even thank those that have signed on. The 3 of our Oregon representatives have, and we will be thanking them. But please nudge the others to sign on or thank them for having signed on. Well, we're right at 5:30. Is it time to go surf, Steve?
Yep.
That's right. It's only 2:30 where you are, right?
It looks like there's a bit of a south swell out there.
All right. All right.
Okay.
He looks out his window at paradise.
All righty. Thanks, everybody.
Bye, everybody.
Sorry, it was so late.
Good night.
Thank you for the
Have a
email.
good evening.
I didn't know.